care. He is also the Vice Chair, Department of Internal Medicine, and also chair acclaimed multi-specialty group quality committee. He's also an associate professor of medicine and attending physician, pulmonary and critical care. He has so many certifications, which include neurocritical care certification by the American Board of Psychiatry and Neurology and the American Board of Internal Medicine, which was issued to him in 2021, December. He also critical care echocardiography, National Board of Echocardiography in 2021, critical care medicine certified by the American Board of Internal Medicine, 2008. Pulmonary disease, American Board of Internal Medicine. In internal medicine, he holds American Board of Internal Medicine. He's also a registered diagnostic cardiac sonographer, which also American Registry for Diagnostic Medicine and Sonography. His education stands, incidentally, he started his education in Nigeria. He had his MBBS, Bachelor of Medicine and Surgery, from University of Jos, Nigeria in 1997. He did his residency in internal medicine, Maimonite Medical Center, Brooklyn, New York in 2005. He has his fellowship, Pulmonary and Critical Care Medicine, from Henry Ford Hospital in 2008. He had advanced bronchology and interventional pulmonary training, also in Henry Ford Hospital, 2010. He has several awards and honors, which include Physician Excellence in Teaching Award by JPS Medical Staff in 2019, Top Doctor Recognition in Critical Care in Pulmonary Medicine, 360 West Magazine, 2020 to 2022. He also has an Outstanding Teaching Faculty Award by the University of Southwestern in 2016. He has so many membership, which include Acclaim Quality Committee, Member Clinical Steering Committee, Infection Prevention Committee, Co-Chair MFM ICU Committee, JPS Health Network. He has so many, he has presented so many, he has so many publications in international journal, and he has been invited to give lectures in so many fora like this. I hereby have the privilege to present to us Dr. Razaq Badamosi to do justice to this lecture. Thank you all.
Thank you so much, Dr. Aghadi, for that very warm welcome. I really appreciate it. Thank you. And really, I just want to thank the I-CCSN again for giving me an opportunity to talk about this topic. This is really a topic I'm extremely passionate about. Most of my work this day is actually in quality and patient safety. I still spend some time, about 6 to 8 weeks in the year, to round in the ICU. But outside of that, most of my work is in quality and patient safety. I lead a team of about 60 people in my organization to actually focus on quality and patient safety. So I will dive into quality improvement and patient safety in the ICU. Closing the gap, this is the theme of this conversation, closing the gap between the care we intend and the care our patient actually receive. For the elders in this organization, they will quickly see where I picked that from. It's from 2001 Institute of Medicine publication, Crossing the Quality Chasm, right? Really, what is that? How do we bridge the gap between an individual expert clinician that really knows how to run medicine, in this case, ICU, and lead a team, and the intended care they are capable of providing, and really now going into team-based and having that 30,000-foot view of healthcare delivery that we are delivering for our patient, and really wonder and look at how our patients are receiving the care. All right, I'm going to start with a case because I think that usually help focuses attention. So this is a very simple case that we all probably have seen one version of or these one version of this or the other in our ICU. 65-year-old gentleman admitted to the ICU 2 days after partial colectomy. On post-op day 2, he reports increasing abdominal pain and discomfort. An abdominal X-ray shows retained laparotomy sponge. A CT of the abdomen and pelvis confirmed it. That evening, he returns to the operating room where the sponge from the first procedure is removed. Now, let's focus on the patient. How is the patient receiving this care? One, there is an unintended foreign object. Yes, patient has undergone a second operation with added risk and recovery. The real way to understand quality and patient safety is not to look at it through the lens of an expert. Look at it through the lens of you, yourself, or me, a patient, or your loved one as the patient. That really clarifies quality and patient safety. So what has this patient had to endure by going to the OR the second time and all of the risk associated with that? So how do you think of this case? Would you say this, what happened here is a known complication? You're not seeing my slides?
Yes, we're not seeing them.
We're not
Oh.
seeing your slides. We're only seeing your face.
Oh, let me just make sure we are getting this right. Can you see my slide now?
It's coming
Yes,
up, but it has
we
not.
can see your
Yes, we
slides.
can see the slide now.
Yes, we can see it.
All
We can
right,
see the
thank you.
slides
Thank
now.
you for letting me know that. So you can see this is the case I just presented of the 65-year-old gentleman with the retained sponge from the first surgery and the patient impact. What do you think? Is this a known complication of the initial procedure? Is this a medical error? Is this an individual surgeon's incompetence, or is this a systems issue? Just think about that for a moment. What happened? How would you deal with this real case, right? That I'm sure for a lot of people, you have probably seen a version or two of this before. Now, but you will have to look at it. Was the count reconciled before closing? Did anybody pick it up in the OR? Is there a policy that says you must do sponge count? If there's any question, was imaging used before the patient was closed up with the initial surgery? Where did the chain break initially? Under normal circumstances, everybody will probably say this is an individual surgeon's responsibility because we tend to think of quality and safety as the responsibility of the expert. But in this particular instance, it is not the surgeon's issue. It may be in some cases, but in this case, it is not. This is a systems issue. It's a failure of design process, and we'll walk through how to think about that in subsequent slides. Another case to get us started and warmed up, something we all know very well, right? Sepsis care. We all know we should recognize it early. We all know the importance of early antibiotics. We all know we have to resuscitate our patient, focus on source control, and then reassess the patient to make sure all of our interventions are working well. So with that background, let's look at this case. Another 65-year-old, by the way, all my patients are 65-year-old. I had to anonymize as much as possible. Another 65-year-old patient presenting with fever and cough, shortness of breath on a very busy day in the hospital. The consultant is tired, as are the resident, are the nurses. Everybody was just trying to get to the end of the day. It was recognized that this patient is septic. An antibiotic was ordered, but it was delivered by the pharmacy 2 hours later. The nurse was very busy with another patient because, again, they have 6 patients they had to take care of. And antibiotics was administered 6 hours after patient presented. Unfortunately, but not surprisingly, patient became hypotensive. The medical intern was not responding to pages because she was busy with a procedure with another patient and no fluid was administered. Vasopressor started only after prolonged shock. They put in a central line because they had to rush it. It was emergent. Patient bled a little. And when they were leaving after a very tired day to go get some well-deserved rest, handoff was incomplete. By the morning, the patient had multi-organ failure, purple toes and fingers, ended up with some transmetatarsal amputation. How would you think through this case? Is this a knowledge problem, a resource problem, a teamwork problem, or a system problem? Right, we can discuss this down the road. Almost always the combination of all four. Almost always. You will, if you analyze the case using all quality principles, that will be the inevitable conclusion you'll come to. Now, after those cases, I really want us to level set. I will be using certain words that I really want to make sure we have some shared language and understanding around. When I use the term quality, I really mean it is outcomes focused. How are we providing care to patient that gives them the best chance of the best outcome, right? It's an outcomes focused meaning. And when we talk about outcomes, it's both clinical, right? A patient comes in with pneumonia. Did we give them the right antibiotics? Did they get better quickly? But more importantly, how did they perceive the care we are providing, right? The patient perspective, right? What defines quality is not us. Our patient has more input in definition of quality care than we do. So what is the patient experience? And another way to understand that is this. If a patient comes under our care and we provide the best care like we will normally do, but they end up feeling dehumanized and disrespected, they have not gotten good care. Or they can come, we give them the best respect, we respect them, but we give them lousy care. Right, they have not gotten quality care. So both of patient experience outcomes and clinical outcomes goes together. And our patient gets to define what quality care means. We cannot insist, oh no, we gave that man quality care. No, did the patient do well in a timely fashion? Did they feel respected and humanized during the process of care? The next thing is safety. When I use the term patient safety, it's really ensuring what it means technically is that a patient under our care do not acquire another diagnosis that is not normally part of the natural evolution of that disease process. Right. For example, a patient comes in with pneumonia, an 80-year-old lady, and they developed pressure injury, pressure ulcer, a sacral decubitus ulcer under our care. That is harm. A patient comes in, they have pneumonia, but on day 6 of hospitalization, they develop PE. We are responsible for that. We could have prevented it if we have good quality systems in place. So patient safety is harm. Sometimes quality and patient safety are used interchangeably, but I think having this perspective as we go into the conversation and discussion will really help put things in their proper place. The next concept is efficiency. This is what we focus on. We are very good. How can I finish my round in the most efficient way? How can I see the maximum number of patients, right? Do we have adequate staffing? Do we have adequate number of nurses? Do we have adequate number of physicians? Is our equipment working? So all of those are important and we should continue to focus on them. They are the bedrock of providing care to our patient. So it speaks more to resources, efficiency of care. Then quality improvement. That is the work that we do to actually close the gap between the care we intend to provide and the care our patient actually get. Right. So that is what will bridge the chasm between care provide, intended care, and care that the patient actually gets. And unless we pay attention to those, we will be defining to ourselves that we're doing a good job. But that is just a story we tell ourselves. Unless we systematically investigate and ensure that we're actually providing good care. So quality improvement is that disciplined and intentional effort that we undertake to close the gap between the care we intend to give and the care our patient actually experience and they receive. So this is the background that I will be using moving forward in talking about my presentation today. How common is harm in the ICU? Bringing it home to the intensive care unit. About 5%, please correct me if this is not the situation in Nigeria or wherever you practice, But I know in the United States and Canada, the data is very conclusive. 5% of hospital admission typically go to the ICU, but a quarter of all adverse events happen in the ICU. So this is the central station of harm, ICU. And if there is anywhere that deserves quality improvement, it's in the ICU. For you can see the bulk of it happens there. So it deserves the focus that will be given to it in this talk today. And whether you know it or not, about a third of the patient that you admit to your ICU at least will develop an adverse event, right? And majority of those are preventable. And in a significant number, they are life-threatening or fatal. If you don't look for it, if you don't have a process in place to look for it, you will miss it. Okay, that's the United States. Looking at developing countries, what's the situation? And this is a paper, they actually did a very, very good job with this paper. They looked at over 15,000 patients across 26 hospitals in Middle East, Asia, and Africa. And they looked at it. What is the prevalence of harm? What is the story, right? And they came up with about 8%. That's about 1 in 10 patients of admission suffer an adverse event. Again, this is broad admission, not ICU admission. And they came that their conclusion was about 83% of those events are preventable. And look at that number, 30% of patients that suffer adverse event actually died in this paper. And it adds about 10 more days to the hospitalization per event. So the problem is there. If I were here today to preach to you that there is something you can do in your ICU to reduce your mortality by 10%, that it's this magic pill, you all will tell me you will sign up for it. So I'm grateful that you signed up for this as well. So again, they were like very clear. The authors of this paper were very clear, right? The leading contributors were inadequate training. People are just not aware. Supervision, processes, structures, and failure to follow those structures and protocols where they existed. Not really lack of equipment. Bringing it down a little bit further, what's in Nigeria? I found this very impressive paper, actually. Very, very simple, but powerful nonetheless. They looked at 309 surgeons in Enugu, and more than half of them had a poor perception of patient safety issues. And only about 1 in 10 regularly use protocol to prevent wrong site surgery. Just think about that for a moment. And only about 4 in 10 were even aware that such protocols existed. The first people to come in contact with our patients that see them every day, our house officers, we all know how it goes. 100% of them knew of no such protocols to prevent harm in the hospital. And on the right side of the screen, you will see that the consultants were very aware, but the residents were less aware and the interns had no awareness at all. That really says quality improvement and safety has to be taught early. We have to start early if we're gonna really develop quality improvement. So during house officers orientation, this has to be part of the orientation. In medical school, there has to be more intentionality about quality and patient safety. What drives harm? This is another great paper that was published in 2020, and it really kind of like drove on the point that 100% of the people surveyed said they've been involved in safety incident. And over about 2/3 said that happened in the past year to them. And this paper identified physician stress and burnout and communication and feedback as major driver and barriers respectively. So this is kind of like really some of the scope of the problem as best as I could drill down to the Nigerian context. Now let's look at the patient perspective. What does it cost the patient in the ICU now, critical care setting, right? We've spoken about hospital. Now narrowing it down, we know 25% of harm in the hospital happens in the ICU. So there are it adds about 6 more days to ICU stay. and about 18, 19 days to hospital days when the patient experiences harm in critical care settings. And about 50% higher, 50% of those patients will die, compared to about 30% in the general hospital. So it's more consequential in the ICU. It is also very expensive for the organization that will be treating this patient. Because if you have a central line bloodstream infection, catheter-associated urinary tract infection, serious drug adverse event, you really spend a lot to take care of those complications. How does it happen? Harm happens because of assumption, overconfidence, blame, shame, and naming. And I'm going to explain a little bit further. The reason I'm going through safety and harm first is you cannot improve what you do not know or what you have not thought about. So we'll talk about the improvement process in a few slides down the road. But really looking at harm, how do harm happen? What is the anatomy of harm? There are active failures, which we are very aware of, right? You're trying to use an equipment that malfunctioned real time. That is a failure. You'll pick it up. Right. Somebody wants to administer a medication that you know that is not how that medication looks. That is a terminal event. You are picking it up right there. So, but something led to that. There are latent conditions that if you do not think about will lead to that terminal event that you will typically will pick up as an expert, right? The hidden setup, the decision, what was the preventative maintenance on all equipment in the hospital? Right? What was the staffing, right? Did somebody cut back on staffing without you knowing? What was the design decision that was made long ago that made that error likely? Because there is a number that you have to know. For every single error or safety event that you pick up, there is about 10 to 15 more that you don't pick up. And that is called the iceberg effect, which we'll talk about. This is another concept in patient safety, the Swiss cheese effect. This is extremely important as a background to understanding what we'll be talking about in terms of quality improvement. You see, this is us right here at the bedside. This is what we have influence over. This is the rounding consultant making all of the decision in terms of what happens to the patient. But there are a lot of other determinants that are happening before it gets to that time where you are rounding as the consultant or as the physician taking care of the patient. The policies in the organization, the design, the culture, that is a weakness. The equipment and checks, the team and handoff, all of those are potential source of error that can allow a hazard or a harm event to reach a patient. But we focus way too much on this alone. This is where our confidence lies as practitioner of critical care, as intensivists. This is really what we focus on. But this is a minority of harm event. A lot of it is determined by this. This is where you can see, even rough math, 75% of it is taking place there. So that is the Swiss cheese model. And everything have to line up for the harm to reach the patient. And it's not all of it that you will pick up here as the consultant or the physician taking care of the patient. If you miss it, it hits the patient. But we all know we will make mistakes. Okay, confidence. This is the Dunning-Kruger effect. This is really, really very important because it speaks to heuristics, right? In terms of thinking about harm. You cannot. And I think our fathers and senior colleague on this call, this is something that they have known. You cannot go confidently in your system and say, oh no, my ICU is perfect. When I'm rounding, everything is fine. I make sure everything is fine. That is a lot of confidence, but that's not how it works. The more your confidence, the less your knowledge or experience in any field. You will get to a point where you will know everything has to be tested. Everything is complicated. You have to have a process in place to really deal with that complication and variability that you do not want to reach the patient. All right, how do you now manage that complicated task in the ICU? It really has to be checklist, timeout, and second looks. And a lot of quality improvement we learned from the aviation industry and nuclear industry. Those are the principles that we learned and applied to healthcare that has really helped us a lot, right? Before we jump on any plane, we do have confidence that when we take off in that airplane, we're going to land where we are going to, regardless of the number of turbulence, regardless of who the pilot is, regardless of who the air hostess is. Our confidence is predicated on we know the pilot is required to plan the route, to look at the maintenance check, to make sure pre-flight checklist, everything is okay. So regardless of their skill, there are a lot of fail-safe technology on the plane, fail-safe actions that they need to practice and before we take off. Otherwise, if the pilot just goes, I'm just jumping in the plane, let's go, we all are going to be worried. Timeout is another thing, like the first case that we presented. All surgical cases, you start with timeout. Second looks, we'll talk more about. So let's get into the QI itself. Quality assurance, what is it? Just ask a simple question. Did we meet the standard? Quality improvement is how we make the system better. Patient safety is, do we prevent harm? Audit, this is the beginning of all quality improvement process. What is our current performance? So if you go back to your ICU tomorrow, or you start thinking about your ICU after the conversation, the critical question is the audit. That is where all quality improvement begins. Objective, using evidence-based tools to really ask, where are we and how are we doing? And we're going to talk about some of the areas to look at where the problem usually lies in the ICU that can cause harm. Then, after the audit tells you where you are, what is the reality, what is your story, this is independent of what you think of your ICU. We now start talking about how do we now improve. But at an individual level, we need that. We need that audit to start. And of course, research. Research is important, but quality improvement really touches the patients immediately. It improves the care and it pays dividends immediately. Research, before it becomes adopted widely, we were talking prior to starting this lecture, will take several years before it becomes widely accepted. All right. So again, these are the rounding up the talk on patient safety. Some of the tools we use from the perspective of patient safety is grow the knowledge base. Part of the knowledge base is the audit. What is going on in our ICU? Where are we? Where are the latent errors or latent issues that we are not seeing unless we go look for? If errors have happened in your ICU before, how did we learn from them? And how did we build system to prevent it? That will raise our standard. That is a quality improvement, right? And what evidence-based tool are we using to learn from our system? I've listed a few. That is really, I feel this is an introductory high-level talk, but we can delve into each and every one of those tools, some of which we will in subsequent slides. I alluded to this earlier, the tip of the iceberg, right? For every safety or harm event you find out, you're only seeing the tip of the iceberg. There are 10 or 15 more that are going on in the background. So where do harm and quality issues reside in the ICU? Right. Infection, healthcare-associated infection, procedure-related event, adverse drug event. These are where to look when you are conducting your audit for quality improvement in the ICU. Delayed recognition, communication failure. This is where the problem is usually. Is that communication? You gotta pay attention to that. And device-related events and general care event like pressure injuries and falls. Failure to rescue. This is important. This is one of those 8 buckets in the prior slide. Failure to rescue. What is that? We all know in our practice, excuse me, the likelihood that a patient is going to develop a complication in the ICU that is part of the course of their normal disease evolution is based on their pre-health comorbidity or the surgery they have undergone. That is their risk, right? If somebody is morbidly obese, diabetic, chronic kidney disease, they're at a higher risk of developing complication. But the likelihood that they're going to suffer harm or death from developing complication in our ICU depends on our system of recognition and intervention. So how do we identify complication early and intervene to prevent long-lasting harm or death? That is the rescue part. So failure to rescue means a complication happened and patients suffered long-lasting harm or death. So we have failed. So thinking about ICU, you gotta think, what is our plan for every patient that develops complication at 2 a.m.? Not during your rounds, we probably will see that. When you are not there, what is the plan? So we need early warning tools, right? Modified early warning score is one of those. That's just really based on vital signs that they should be monitoring. Yes, they are monitoring vital signs in the ICU, but are we integrating it and scoring it such that if somebody MUSE score, modified early warning score, is 2 as an attending or as a consultant when you're rounding, then at 2 a.m. it jumps to 7. Something is about to happen. It's telling you that something is going to happen. This is a cheap tool. It's just based all on vital sign. Then what is the process for evaluating further and intervening? So that's something to think about as you begin an audit of an ICU to see where are the gaps, right? And that will help you develop escalation protocol in the ICU. Of course, we all know this. This is bread and butter ICU that we do every day. What is our ventilation protocol in the ICU, right? How do we have a protocol? If we are not there, do our house officers and residents and registrars really know, will this bundle happen? If they don't do it, will a nurse speak up? Is a nurse empowered in our ICU to speak up to say, hey, we've not really done the ventilator bundle on this patient? Is this something that is mandatory and hardwired into our system? We may do it, we may think of it, which we do, I'm sure of that, but is it done automatically every day, every patient? Lines, tubes, and drains, do we do a daily necessity assessment? Because we know if any line, tubes, or drain that you have in a patient is a source of infection, and that is a complication, it's associated with increased morbidity and mortality and length of stay in the ICU, right? Is there a daily requirement to review it, right? If we no longer need it, let's take it out. Is our team empowered based on how we have protocolized things in the ICU to actually remove it or highlight it during their presentation to you that, hey, this needs to go out. Do you agree? Right. So this is part of the audit process that we really have to think through. Where do latent harm hide in the ICU? Line, strains, and tube, ventilator management, failure to rescue. Then diagnostic safety, right? About 5 to 15% of ICU death is because of a missed diagnosis. That's about 1 in 10. That's a lot. So how do we handle that? That diagnostic excellence. How do we communicate uncertainty? How do we get a second opinion from our colleagues? What causes it, right? And how do we identify it? How do we create a systematic tool? For example, in my organization, if a patient gets transferred out of the ICU and they are readmitted within 72 hours, we review that case. If a patient gets admitted to the hospital and they are transferred to the ICU within 24 hours, we review that case. Why? Because somebody probably missed something. Not always, but sometimes people miss something. We just have to look at it. Did they get all of the labs and imaging that they want? Was it available or was it delayed? Was critical result communicated early and quickly? Right. So missed diagnosis. Are our team during rounds empowered to speak up if they observe something? Or is our hierarchical system preventing such ability of people that are junior to us to speak up? Skin and mobility also, pressure injuries, it happens a lot. What do we do to prevent that? This is a big problem, right? Do we have a protocol in place? Because if we do not have a protocol in place to prevent it, it will happen. It's inevitable. Handoff. This is very important in ICU. Again, a lot of sentinel events really ties back to communication failure. Do you have a standardized tool for handing off? Because it's not just communication, you are transferring risk to another clinician that is taking over. Is it structured? Do they cover everything? Is it uninterrupted? What do they need to do if something goes wrong? All right, let's talk about a third case. An elderly man was admitted to the ICU for sepsis and renal failure. Patient had poor vascular access. Central line was emergently placed. 30 minutes later, patient became hypotensive with worsening shock. Imaging showed hemothorax. Patient required a chest tube. Is this a known complication or a medical error? Right. So we usually, when we are doing procedure, we will tell a patient that, well, you're undergoing procedure X. I have to let you know that you can have pneumothorax in case of central line. You can have hemothorax as a complication anytime you put in a needle in a patient. You can have any other form of unspecified complication, which we disclose to patient as we should. But there is a critical element to that. Because we disclosed it a priori and it happens, does not make it a known complication. It has to go through the 4-question test, right? Was it an appropriate procedure? Was that procedure indicated in the first place? If a procedure is not indicated and a complication develops, it is not a known complication. Did you anticipate said complication? In the case I presented, the complication was hemothorax. Did I know that this patient was likely to develop hemothorax? Yes. If so, what did I do to prevent it? Yes, I used ultrasound. Before I dilated, I made sure I confirmed the location of my guide wire, and I really watched the catheter going in. Did I do all of those correctly? And unfortunately, this still happened? Well, yes. Did I anticipate coagulopathy? Did I check to make sure patient is not on warfarin at home? Right. If they were, did I reverse it? If I did not do that and the patient develops a bleeding or hemothorax complication, then it's very difficult to argue it's a known complication, despite me telling them before the case it is. Then do we catch it in time? Right. If you catch a complication 24, 48 hours later, even though you told them it could happen, but you did not have a system in place to pick up the complication in a timely fashion so you can treat it right based on the best evidence. Unless you get a yes to the 4-question test of known complication, it is not a known complication. It is a system error or an individual error, depending on what the situation is. So what do we do? What do we do for quality improvement? This is the doing part now. Hopefully, I've provided a high-level summary or a journey through quality and patient safety issues in the hospital and in the ICU and some key concepts in quality improvement. But how do we now do the quality improvement? In addition to an audit, you need to have a culture of people being able to speak up. It has to be encouraged and it has to be protected, because without that, you're not going to learn what you need to improve. You will not know where the problems are. People are going to hide things, right? And we got to change the question from a culture of blame, naming, and shaming. So long as there is no individual recklessness, it is almost always has a problem of design and system issues that we did not pay attention to before it happens. Each case where we have a failure deserves a root cause analysis and action. What does that mean? That is the first tool I'm going to talk about. You have an event that happened that is adverse, right? The first thing to do is, instead of asking who made the mistake, it's what made this possible in our ICU? What do we need? What system do we need to redesign? How do we ensure that if this ever happens again, somebody is able to speak up and escalate? And how do we standardize to prevent it? In my organization, what we do is to adopt the IHI a methodology for root cause analysis, right? 3 meetings, right? First meeting is senior leadership and executive awareness. My team will call for a meeting. We will let everybody from the president of the hospital down to the chief nursing officer, chief medical officer, chief of operation, everybody will know. And we have a standard of within 24 hours. This terrible thing has happened. Everybody knows. The next thing from that day, that within 24 hours, is we must come up with an immediate risk mitigation. How do we minimize the impact of injury on the patient? 2, how do we ensure that another patient in an exact same situation do not develop or do not experience that harm? That we have to do within 24 and 48 hours. Then the next step is disclosure. We have to tell the patient and the family that an error has happened. That is the first step of an RCA. Senior leadership and executive notification. We have to be aware, we have to develop an immediate risk mitigation, and we have to notify patient and family. The second step is, and people will think when you do that you get a lot of lawsuit. That has not been my experience in all my years in quality and patient safety. That has not. In fact, dramatically reduced the number of lawsuits that we get or even settlement. It just doesn't happen. When you treat people with respect, with full disclosure, and you're able to explain what happened, people are human. They really forgive. So that's the first step in our RCA. The second step in RCA is the core team meeting. All executives, everybody are banned from going to the core team meeting. It's really about the frontline staff, the nurses, the patient techs, everybody involved in the care of the patient that get together to now analyze what happened. What did we do wrong? What were the factors that led into this? And the third meeting is the debrief, where we all get together now with the action plan. What can we do to make sure this does not happen again? And we follow it up because there has to be sustainment for 6 months, 1 year, 18 months, and 2 years before we close it, so long as all of those actions are resolved. So audit is the first step in quality improvement. The second step is having a process of awareness and escalation to be able to determine root cause of problem, right? And to develop system changes to ensure it doesn't happen again. Your audit may not start from a problem like I just described. It may start from, you know what, we can really do this better. We want to give antibiotics within 60 minutes. Our audit reveals that we're currently at 45%. How do we get it to 80% in 6 months? So audit, what is our aim, right? How do we measure it? What is the median time from sepsis recognition to first antibiotic dose? We have to collect that data. What do we need to achieve this number? Do we need to create a sepsis card? Do we need a code sepsis in the organization that will mobilize all of the resources? Do we need to keep emergency antibiotic stock in our triage area, in our ICU? What will be our trigger? So this is a simple, basic QI project that you can apply not just to sepsis, but to any diagnosis you want to make better, or any process you want to make better. Aim, measure, change, right? The next is PDSA. PDSA, you test small, you start small. You learn fast, then you spread. The key to PDSA is we cannot boil the ocean. You gotta start small. Plan the change. What did our audit reveal? Or have we had a lot of issues that is apparent in this ICU that we need to fix? What is the evidence-based fix? All right, let's do it. Maybe 3 beds or 1 shift in the ICU will consistently apply this methodology. Did it work? And the other critical thing with PDSA is don't go it alone. It gotta be multidisciplinary. If needed, pharmacy should be part of the PDSA. Nursing must be part of the PDSA, must be. And it always helps to get executive or administrative sponsorship, right? Okay, we are starting this project small here, right? Let's do the change. Let's study, let's see what the effect of the change is, and let's act on it. If it works, let's adopt it. Let's scale it. Let's spread it. If it doesn't work, is there something we need to change? Or do we need to abandon it and start all over again? Right. Don't start with a hospital-wide policy. Don't start with an ICU-wide policy. Look for subset that you can influence and easily measure for PDSA. So, again, resources help, but honestly, one thing quality and patient safety, my journey has taught me is you really, really gotta go back to the basics. Every time I see it, resources really, really help. I cannot understate that. But what are the measures in the ICU that we may need to audit? ICU mortality. What is your ICU mortality? Crude ICU mortality. Can you break it down by diagnosis? That is the global outcome signal, right? Sepsis bundle compliance. How many people are compliant with the SEP1 bundle? Breaking it down, time to antibiotics. What is our ventilator days? Right. What is our central line days? What is our Foley days? Foley catheter days. I hate Foleys, by the way. I have a whole thing for Foley. Pressure injuries. How many of those did we have in the last month? How many unplanned extubation do we have? And what is our 48-hour ICU readmission rate? Right. So we can start with these key issues that will expose in critical care settings some opportunities to improve. This is a good project for medical students, for registrars, for anybody across the spectrum that we can use to improve care in our ICU. Again, just kind of like an example of what I have already described, to improve from 45% to 80%. Audit, what is our goal? How are we going to measure it? What changes are we going to, right? There is something called balancing measure. You don't want to overuse antibiotics as well. So you may need to conduct a separate measure as well, such that as you're improving this, you don't worsen this, right? You got to balance it. Balancing is inappropriate antibiotic use. Then how do we sustain it, right? It got to be iterative as we are doing. We learn, we improve. Just for emphasis, why do QI effort fail? A lot of it fail because too many priorities. You gotta choose one first, right? You gotta measure things well, right? If somebody can obviate peak hole in your data, it's not reliable. Don't do it at a high level. Involve frontline staff. This is their lived experience. They do it day in, day out. Eliminate punitive culture in your ICU. People should feel free to speak up. We gotta be people that finally do away with hierarchical structure. It really doesn't help. It doesn't help our patient, right? And you gotta share your data. There is no need to hoard it. Even early data before it's published, you can share. Work in progress, WIPs, right? Share the data of what you are seeing. Get input, and people will have more buy-in. This is a paper I also found that was sponsored by this organization, kind of like looking at what about in resource-limited context, right? This was published by some of the elders of this organization that really highlight the resource limitation in Nigeria. But as I mentioned, standardization, checklist, escalation pathways really, really can help a lot. Limited ICU bed, what's our triage protocol and step-down criteria? Do we have it? Right. What's our early warning system that we have deployed? Equipment constraints. What is our manufacturer instruction for use? And are we following that in terms of preventative maintenance and handling? Nurse ratio, right? If we have few nurses, if we don't have a lot of nurses, right? How do we have escalation and checklists that can help? What about order set? Sepsis order set. We have order set. We have a chest pain order set. We have order sets for a lot of things. What about standing delegated orders? to really help so that a nurse will know I identified this problem. We have agreed if this happened, this is what I can do. It's within the scope of their practice and knowledge. Delayed presentation, medication availability, data limitation is another one. A simple Excel sheet. Excel sheet is so smart these days, especially with AI. Excel now has Copilot. You can do a lot more with Excel to collect data, analyze data, and hierarchical culture. That's psychological safety. You gotta break it down. It gotta go away because even in resource limited context, if you maintain an hierarchical culture, people are not going to speak up and you will not be aware of what is going on. You gotta encourage escalation, right? It's really not about perfect resources. It's really making do with what we have, but building reliability into it with intentionality. What can we do tomorrow if we are not already doing it already? I'm sure a lot of ICUs are doing this, right? Checklist, safety checklist. Do we have sedation goals documented? Has this patient undergone breathing trial? Daily on every patient, nutrition plan. We do this, we know it. There's nothing new I'm sharing here, but just need to protocolize it before moving from one patient to the other. We have this. I use this every time around in the ICU. And we monitor the use, right? Checklist. We adopted the Choosing Wisely from Society of Critical Care Medicine, and we embedded it in our rounding tool. And we go through it, checklist every day. Have we done this? Did we discuss sedation? Did we discuss SAT, SBT? Did we look at antibiotics? Have we spoken to the family? Do patient need line and Foley? Before we went electronic, even as a fellow in Michigan, we had it on paper, something similar to that we're going to check to say, okay, we've done all of this for this patient. Let's move on, right? And I highlighted patient experience as well. That's part of family update, discussing with the patient and having them participate in the care. Is zero harm possible? Can we get to a situation where we can eliminate harm? I was in Michigan when this study was done. This is the Peter Pronovost study, and some of our elders in this group will also know about this study. Yes, it is possible. We can eliminate harm. We just gotta be intentional about it. When Peter Pronovost started his campaign in Baltimore, that you can eliminate central line infection by just really following these 5 simple steps for insertion, a lot of people were skeptical. Then he came to Michigan and he did a multi-ICU study, real life study, both teaching and non-teaching hospital, to show that if you follow this checklist and bundle ICU central line insertion bundle, you actually can reduce your CLABSI rate to 0. A lot of people were skeptical, but the data, it still stands the test of time. And it's changed a lot of people's lives. A lot of lives have been saved with just simple intervention. Wash your hand properly before you put in a central line. Make sure you have a sterile gown on. Protect your field. Clean properly. All of simple stuff eliminated central line infection. You can see the result. And it held even after implementation for up to 18 months. And it's still holding 20 years later. So zero harm is possible if we thoughtfully audit our system, listen when things go wrong, have a pathway and psychological safety for our team to speak up, evaluate those events using a validated tool of root cause analysis, and develop action plan, follow through on those, develop an improved system using PDSA. Using audit, aim, measure, and spread, we can do a lot of those and really lead to zero harm and better care for our patient. We can actually do a lot of this together. I am very willing to collaborate with anybody that's willing in the QI space. We can build a reporting tool, measures and checklists. We can spread and diffuse ideas between ourselves, develop QI projects, share what we have learned and what worked, what didn't work, which tool we are using. And the evidence is clear. I was telling Dr. Akideno before this talk that in looking at the literature, just reviewing literature in preparation for this talk, the need is urgent, and we can make and build the system. And I think the ICC, excuse me, is really positioned as an organization to be the champion of this. If it works in the ICU, it can work anywhere in the hospital. And definitely there's an opportunity for collaboration here, for cross and mutual education and curriculum development, even for medical students that are upcoming. The next life we save in the ICU may not come from a new drug or a new machine, but from making essential care reliable every single time. So there is more to speak about quality improvement. My apologies if I've covered material that everybody knows before now, but my intention was to provide a very high level, broad, the way we think of quality and patient safety and quality improvement. Most of the slides that I shared today are a presentation and a topic of discussion by themselves. So my attempt was to high level, focus it on the ICU and get the conversation started. Thank you very much again, and thank you for inviting me, and I will take any question.
Dr. Aghadi, please, over to you.
Okay, sir. Thank you so much, the presenter. I believe we have had a lot and we have learned a lot from him. He's a seasoned quality assurance in ICU. So if there's any question, I cannot see any question in the chat box. You can raise your hand and ask your questions now. Any question? Is there any question in the chat box?
I see a few people have raised up their hand, so I'll defer to you to recognize them.
Oh, okay. I have seen Professor Elizabeth Obolinwaso. I can see her hands up. You can unmute yourself and ask your question, ma'am. Thank you.
Okay, thank you very much, Dr. Razaq Badamosi, for that very well elucidated lecture. I really learned a lot, and I could, relate with a lot of the things you said and a lot of the examples, the case reports you gave. My question is, from what I think, we have a lot of problems with some of these issues that you brought up. How do we build our systems? How do we make our systems to be robust enough to improve our patient safety and quality in our Nigerian practice?
Absolutely. That's a great question, Prof. Really. And it really starts, in my mind, with a lot of collaboration. I had been practicing critical care for over 10 years before I got into the safety space, quality and safety space. And I really just look back. The first step is awareness. We gotta be aware, like you pointed out in your question, Matt, that there's a problem and we can fix it. And there are tools that can actually fix, regardless of the context or situation or resources, there are tools that can actually fix it. All it will take is an evaluation and audit. And in this case, one of the things I realized also in preparing for this talk and trying to look for literature, search the literature to gain some understanding of quality and patient safety in Nigerian context is there is not a lot that has been done, or there is not a lot that has been published. I'm sure a lot is being done. So, one, awareness; two, collaboration. Really. Three, building the tools. We can build the tools. These are things that one could get grants for easily because it has to do with safety. You can, if people really are dedicated and committed to these are something that there could be grant funding to. These are something that is easy, achievable, scalable, and you can publish. So many easy things to do. And in this day and age, especially, we are living in very, very interesting times that you can actually design electronic system that will work for your own particular context, right? With artificial intelligence, so many things have been done. Things that I didn't think were possible before. Things or data that I will bring home and spend a week analyzing, day in, day out, trying to figure out. I can analyze now, I know what to do in an afternoon. So it's really a great time for collaboration, for building, and for spreading awareness, right? That this is possible. That will be my response to that.
Thank you,
Thank
sir,
you
so much for these answers. I can see Dr. Irene's hand up. Please, can you unmute yourself and ask your question?
Well, thank you so much, Dr. Badamosi. I think it's really an eye-opener. I know a lot of us in our ICs and the way we work, every day we try to improve, but sometimes we're a bit, we really don't know how to go about it, because, like you say, you have to start from somewhere, find out what you need to improve, then, assess the system again. And I think this lecture has really opened our eyes to see that. You talked about resources, and having resources available. If we look at the aspect of sepsis now and even following the six things in sepsis, not so many hospitals can actually do that for these patients. We have out-of-pocket payment. So that affects even the patient getting their first dose of antibiotics, So how do we do this quality improvement in the context of a poor form of health insurance, and purchase of equipment, and all of that are issues. Investigations are done based on if patients have money in their wallets or they have to go and pay. So, it's not based on, oh, I think I need to have a blood culture now and get it done now. I know I have to do the blood culture, but the relatives probably do not have money. So blood culture isn't done at that time. And maybe the sample, they don't even keep the bottles in the ICU. So patients have to pay first.
All right.
Okay. Hello. Okay. Yeah, sorry. So patients have to pay first before they can even get the blood culture done. Then the samples are taken probably when patient is no longer spiking. So how do you because somehow we still need to have this QI stuff in our climb, So, how do we navigate some things actually beyond us and still be able to get some validation, and some results really that we can actually push out to the public domain? Thank you.
That is an amazingly great question and a difficult one, but I will tell you, this is kind of like how we do it. The goal of quality improvement right off the door is not to get to 100%. There will be a subset of your patient, right? And you need quality improvement will actually help you identify them. Let me use the example you just used. you have 100 sepsis patients needing to make sure you hit SEP1 compliance in them. And SEP1 compliance is antibiotics, fluids, blood culture in sepsis. You probably have 40% of them that's limited by financial reason, financial constraint that will not be able to afford to do what you need to do in a timely fashion. But you gotta know your number of people that can afford it, that come to your center, that everything is okay. What percentage of those are you hitting? It's not the 60%. It may be something between 40 and 50%. Well, you do have a 10 to 20% gap to close. When you close that, you are now able to go make a case, either in terms of fundraising, to the hospital administrator, to the Ministry of Health, to federal government, to whosoever that can do anything that, hey, look, in this group of patients that we have done this quality improvement, this is their mortality. The reason this other group of patients are dying is finances. We will continue to work at it, but whatever assistance we can get with them, you can make a case, but you cannot make a case without quality improvement. You cannot just be saying, oh no, this group of patients cannot afford it. It strengthens the case of advocacy if you can show data, even in its most basic form. If you say the mortality in the 60% after your quality improvement that gets SEP1 bundle compliance the way it should be done in sepsis management, mortality is 5. In those that do not, mortality is 50%. Now you have another strong data to back up any ask. You'll be asking of NGOs, you'll be asking of government, you'll be asking the hospital administrator to solve. But in the absence of that, you're not going to be able to move the needle as effectively as you would with the quality improvement data.
Thank you very much.
Thank you so much, our speaker. Somebody put in the chat board, but before then, our president hands are up, is up. So I want Dr. Job Otokwala to ask his question. You can unmute yourself and ask your question, Dr. Job.
Yeah, thank you very much. I mean, I'm very much impressed with the quality of presentation that you've made today. I'm sorry I joined late, but I understood everything you said. I want to just make an appeal to you while thanking you for taking the time and initiative to talk to us. We just have to do something to help everybody, those of you in diaspora and those of us who are still in Nigeria. We've got to work together to do something to improve the services we render to our patients in Nigeria. And it starts with one of the key things you mentioned, collaboration. I mean, it was quite unfortunate that you couldn't get enough data to rely on talking to us about what concerns us over here. And it shows that we have a lot of work to do. We have to, you've given us the assignment anyway. There are too many things we actually do together. If it's just the aspect of developing basic checklist for either central line insertion or urinary catheter insertion, or for just basic things. If you're just getting something that is measurable, scalable, if you can actually generate a basic checklist with which you can work together, publish them, and generate enough data that we can use to confront. We have myriads of problems in Nigeria. Everybody is complaining about resource limitations and all that, but we don't have enough data. I mean, it's quite unfortunate, and that is anyway. I think is you've given us a drive, something to work on. That's you guys, we have to work together to let's see how we can generate enough data that people can rely on, to not push for whatever requests we want to make to improve services. We have a lot to do. It shows that we actually have a lot to do together. And it's an humble appeal that I'm making to you that the assignment you're giving to us, we can't do it except you help us work it out for us. We're trying to conduct the ICU registry in Nigeria. And unfortunately, we're working with some foreigners. But with you, with us, I think it's much easier. For us, let's just start with that. And how do we start? It starts today anyway, because I mean, we're in the public glare now. Everybody knows that you are there for us. And then you've talked to us about the need for us to collaborate. And I-CCSN is ready, even now, to start even the most basic form of activity. Generate checklists for various activities. That will be very interesting for us. That is the appeal I want to make. While thanking you. And I think we are not just tired of hearing you talk to us. And we want to employ you to keep talking to us, stimulate us, and let's get this done. With this little effort, you'll be surprised that we're making some efficient and profitable, rendering of services that will benefit even the poorest of the poor, find themselves in intensive care units in our society. Thank you very much. I'm very much impressed. And I think I need to listen to this lecture over and over again. I'm very grateful. Thank you, Doc.
No, thank you very much, sir. Absolutely. Collaboration is the way to go. And I'm definitely ready to, whosoever want to collaborate, we definitely can coordinate with Dr. Akineno. She has all of my contact. We definitely, this is it is, I won't say it's easy, but it's amazingly doable, right? If we want to do it, the tools are there. The tools can be built. There are efficient way to build this system and tools, even in our context in Nigeria, to really ensure that we start somewhere, right? We will not boil the ocean, right? We'll boil it in buckets, but let's start boiling it, right? And there are tools available. As to the issue of collaboration, I'm definitely available. I'm able to. This is what I do every day. Any resources available, so long as I have willing partners and committed partners, we definitely can do a lot in the quality and patient safety space.
Thank you so much for that answer. Somebody wrote in the chat box, please, I want you to speak on the quality management triad within the ICU, because the quality standard and assurance are lacking in our ICUs. I don't know if you can answer that.
That question we need a little bit more clarification. What do they mean by quality triad? Because the quality triad in my mind may not be the quality triad they are thinking of. So if they could kindly clarify, that would help.
Okay, I think the person is HP. But before he does that, there are two hands up. I'm calling on Dr. Ifeanyi Lumelu. Unmute yourself and ask your own question, ma. Thank you.
Okay, thank you. Good evening, everybody. Good evening, Dr. Badamosi. Thank you for your excellent lecture. I actually have the distinction of working in two ICUs. I worked in Nigeria in the ICU, and just as Dr. Irene mentioned, we do have a lot of challenges. Currently, I'm working and practicing here in the Kingdom of Saudi Arabia, and there is a world of difference. They are very big on quality issues here. Every single thing you mentioned in the lecture is part of my daily existence here. Not enforced by me, the ICU doctor. We have teams that come around every so often on daily basis to check. Your VTE screen is something you must insert into the electronic medical records. Your CAUTI, CLABSI, and everything infection prevention. Despite the resources, despite the checklists, human beings are still human beings. I still see some challenges. I'll give an example, and pardon me for talking a bit longer than I should. We still have challenges with the giving antibiotics within 1 hour, as surprising as it seems, even here in Saudi Arabia. Not all the time, but sometimes. You might prescribe your antibiotic, and on 1 or 2 occasions, the nurse is waiting for the morning time to give the dose, and you lose some hours. So if you don't keep your eyes and ears open, patient could still run into troubles. But that said, I will admit that I learned a lot here in Saudi Arabia. And I agree with you that we need to have a lot of collaboration and assistance to give back home. I'm very big on giving back to Nigeria for as long as I'm around. So to reassure Dr. Tokwala, I would also like to be part of the collaboration, sharing what I have seen here. And we try to at least start by working up protocols that can be enforced. As you said, we can't boil the ocean, but we can boil a little bit at a time in the bottles. So thank you very much.
Thank you
So Chief
so much.
Otokwala,
I
I'm
really
loyal.
appreciate your input.
Thank you, sir. Okay, bye.
Okay, I can see Madabushi Paul Ufebunam. Madabushi Paul Ufebunam, please unmute yourself and ask your question.
Okay, thank you, our able presenter and the participants. The lecture just highlighted the challenges we're having, but you know that in our own in Nigeria, there is a wide gap between what happens in the public hospitals, public sector ICUs, to what happens in the private sector ICU. Most of the things that have been highlighted here, there are so many private sector ICUs that are already, working at that level of ensuring quality. And one of the things that, from my own experience, make the difference is the pattern of funding for in the private ICUs as compared to the public sector ICUs. But on a general note, just like our president suggested, we need a collaboration, because we have a lot of lack of adequate knowledge on the part of many of our practitioners. Just like you finish saying all these things, people hear them, people are excited, people are happy, but once we leave the forum and go back to our various institutions, people find it difficult to try to start practicing some of these things that you have mentioned. And I'll be suggesting that as part of what we can drop in the education committee, which can be available in our website, some of these tools could be made available through the education committee to our members, so that people can still go look at them later, and that they download some of the ones they can download and adopt them and start and begin to use them in their various ICUs, one at a time. Gradually, this change will gradually begin to spread. Once again, thank you, the presenter, for the wonderful presentation.
Thank you very much, sir. Thank you so much. I think you make a lot of excellent observation in this space, especially kind of like in funding and resource limited context. What do we do? Here is a paradox. I trained at a private hospital, Henry Ford in Detroit. I worked at Parkland in Dallas, which is a safety net hospital. Then I moved over to JPS, which is also a safety net public hospital. One of the things I can tell you is people that need it most and the impact that you make is actually in those low resource contexts. And I can tell you, it is my lived experience that you can improve quality and safety even in resource limited context. My hospital is not as rich as Mayo Clinic or Cleveland Clinic in the US, but I can compare my data with them any day, anytime. Yes, do we have problems we have to deal with, as Dr. Elumelu mentioned? Absolutely, we do. It is not perfect and bed of roses. But can we show the work that we are doing intentionally? Yes, we can. Especially in resource limited settings, that is where quality improvement is most urgent. In people with funding, social determinant of health and all of those health-related social needs funding and all of those, less impact, right? You solve a lot of problems automatically at that level. If we're really talking about impact, then it's really where funding is limited. That's where you can make the most impact. And that's where it requires a whole lot more thoughtfulness and planning and scaling, starting small. My goal, honestly, is to get one or two people that will be interested in this, just one institution that will be willing to collaborate effectively. That will make my day. Because the reason is, if we can get just one hospital from this conversation that will be willing to collaborate, public hospital that will be willing to collaborate, and we can show what quality improvement can do on scale, adoption becomes easier for other people to want to. I completely agree with you. You have this type of thought, people forget. But the goal is just to get one or two people that will be willing to go to the doing part. Talking quality is easy, honestly. Doing quality, that's where requires some work, some thinking, some design, and some scaling. But it can be done, and it has to be done.
Thank you. Thank you, sir. We are very happy to hear from you. That person has arranged his questions. Now said there is a quality management triad of quality standard, quality assurance, and quality improvement. He now asks, how can these three work together to achieve improvement in patient safety?
That is a next level question. I see where they are going to. It's a step above what we just spoke about. This is the essence of a QAPI plan for an institution. Quality assurance and performance improvement, right? In the regulatory context. I will give an example. In the United States, healthcare is regulated, over-regulated in my opinion, right? But again, the golden rule is determined by the person that has the gold. If we all get most of our funding from commercial insurers and CMS, then they get to make the rules on quality. They say these are the benchmarks that you have to reach in various programs, right? That is the quality standard. They establish that. Institute of Medicine also established some standards. The Joint Commission, which is the regulatory agency for 86% of hospitals in the country that really come to survey hospital, they have standards you have to meet, right? So that is a quality standard that HP is speaking to, right? Then the quality assurance is actually quality assessment. What system do you have in place for every department, programs in the hospitals, and committees in the hospital to regularly come up and report their quality data to a quality leadership group that identify gaps and issues and progress and success? That is the quality assessment component of it. Now, when those gaps are identified, you now go into performance or quality improvement. How do we improve? There is another step, loop closure. Loop closure basically is, how do you ensure that those performance improvement actions that you have developed, that you have hardwired, is actually working? What is the impact on the original data you presented in your quality assessment? So that is the QAPI plan. By rule of CMS, one of condition of participating in CMS is every organization must have a QAPI plan. That really should be the ultimate goal, because it's the unifying program or structure for everything that we have discussed today on an ongoing basis. Realizing that we have to demonstrate as an organization continuous improvement. Improvement just doesn't stop when you do it. We have to continually improve, monitoring, learning, developing action plans, implementing those, hardwiring, and sustaining it, and loop closure to make sure it's actually working. So that is the next level stuff that can be done. But I think we have to start from one, awareness and audit, then we get to a more structured plan like QAPI plan.
Thank you so much. There's another question in the chat box. The person said, please, what's the acceptable duration for the PDSA cycle of the audit process for it to be considered applicable across board?
Oh, excellent question. Excellent question. It really depends on A, what are you trying to improve? B, what is the strength of the data that you have generated? C, what population did you study? Because you can only generalize and scale up in the population that you have studied. Right. Is it a big population, diverse population, or a specific subset of patients? So, for example, if you look at, if your PDSA has to do with stroke patient, you cannot generalize it to heart attack patient. You study 5 stroke patient or 10 or 20 stroke patient, you've seen your data shows, oh my goodness, I have 50% improvement in their neurologic outcomes if we do this. Okay, can we incorporate more, or can we go to all of our stroke patients? You can do that, right? You can, once you're able to show that data and defend it with people in the organization, a multidisciplinary team in the organization. Absolutely. That's the whole essence of performance improvement or quality improvement. You can do that. You can scale it based on your institution data. There are some traps to avoid that people fall into all the time. And we can talk about that in another talk, or if we are called, when we are, that's regression to the mean, so that we will not develop a statistical artifact of improvement, whereas it's just pure regression to the mean that we're observing. There are ways to also factor that into a PDSA, but that's beyond the scope of this conversation.
Thank you so much. I believe we are all listening attentively. I want to conclude, since there's no more question in the chat box and I can no longer see any hands up, I think today's discussion has highlighted the importance of measuring outcomes, promoting patient safety, strengthening teamwork, and continuously evaluating ICU processes to improve the quality of care. So I'll hand over to Dr. Irene to continue with the rest of today's activities. Thank you. Dr. Irene.
Thank you so much, Dr. Ifeanyi Aghadi, for really moderating this session. Thank you to our presenter, Dr. Badamosi. I'll hand over to Dr. Josiah. He's the one actually coordinating this. Dr. Paul Ofegbuda will be the one to give the vote of thanks on behalf of the executive. Dr.
Yeah, thank you, Ma. Thank you, Dr. Razaq Badamosi, for the excellent presentation. We're all glued to our devices, listening attentively. Hopefully, we'll go back and do the needed work in our ICUs. Before I hand over to Dr. Paul for vote of thanks, I would like to remind us of our annual scientific conference coming up next month, between 6th to 9th of July. Please, let's work towards it and register if we have not registered. So I'd like to hand over to the Secretary of the Society, Dr. Paul, for his vote of thanks. Over to you, Dr. Paul.
Thank you, Dr. Isaiah. On behalf of the executive of I-CCSN and members of the I-CCSN, we want to thank our presenter today, Dr. Razaq Badamosi, and equally thank the moderator for doing a good job. You can see that this topic stimulated a lot of interest. You see the number of participants. So once again, this is the second time you are talking to us, so we are grateful to you, and we want to implore you that anytime we call upon you in the future, to talk to us. You are going to oblige us. I equally want to thank the Education Committee led by our Vice President, Dr. Irene, for such a good job they are doing. And I want to equally thank our numerous participants across the globe for finding time to stick to this webinar to the very end. And once again, to remind us that this webinar will be available on the I-CCSN website. So for our members, they'll be able to access it and be able to go through it many times to extract more information that they need to go back to their various ICUs and begin to improve things. Thank you once again for the robust participation and discussion. Thank you.
Thank you very much. Thank you all so much. It's been really a privilege to be able to present before the society, and I'm really, really very grateful for the opportunity and looking forward to collaborating with the society on this topic. This is really a passion of mine. This is what I do, and I'm so happy to collaborate. Thank you all so much. So grateful.
Thank you, sir. Thank you, everyone, for joining.
Thank you so much. So enjoy the rest of your evening.
Good night.
Thank you so much.
Thank you, everybody. Good night.
Good night.
Thank you very much. Thank you very much. Good night.
Presentation. We have what to do. Good night.
Good.
Thank you so much, Dr. Ifeanyi. Really appreciate it. Thank you.
I thank you so much, ma.
No, thank you. Thank you. Thank you. Hello. Hello, Dr. Jedoy. Please, do they know the people? I'm trying to remove some people, but the LOC people need to be here to know who are their members, who has what. Dr. Harrison, please, you know your LOC people so that we can. I'm going to make you a co-host. Dr. Harrison. Hello.
Evening, ma'am.
Yes, good
It seems
evening.
I'm the only member of the LOC here.
So I'm making you co-host so you can look through the persons here. Those who are not meant to.
I'll just call them
Thank
and
you.
tell them to join. There's no member of the LOC present here.
Yeah.
Dr. Harrison, didn't you tell them we'll be having a meeting after this webinar?
Now, they should have
If I
joined
repeated it again and again, posted it again and again.
Dr. Irene, please help me stop the recording. Please help me stop the recording.
Okay. Do I know where to press to stop it? I'm using my phone now.
Just press on more, then that area where you have record. Press on more.
Then there's an area where you see record, just press on it, it's going to stop.